but we need more randomized studies for more solid evidence. Thank you.
Thank you, Dr. Amr. And now we open the floor for discussion. May I take the privilege to ask Professor Nasser Saeed for this huge gluteal hemangioma. Why you ligate the internal iliac artery? As we all know that the nidus in the arteriovenous malformation, especially high flow, we must go to the most distal part to prevent the recurrence and they get excellent results. And I think this large arteriovenous malformation needing a coiling, not by injection of fluid or embolic material.
I just would like to clarify your question. You're asking why I ligate the internal iliac?
Yes.
Instead of what?
Instead of go more distal to the nidus of the
Distal. You mean
distal for
inject?
the yes. You're coiling this part.
I will let the cat out of the bag, okay? This patient has several ethanol injection by an eminent vascular surgeon, have several foam injection without any success. The problem, the patient coming with bleeding, uncontrolled, need to stop it, stay compressing for a long time, and he has a bleeding several times before. So I know skeletonization operation is an old operation, but after sitting and discussing the case, how can we give any benefit? Try, safety come first, try to stop the bleeding. We decided to do this skeletonization. The main connection, or the main problem was in the gluteal region. So he has main two connection with the internal iliac and the profunda. Okay, and the third big feeder around the just above the knee. So we trying to control the problem, and actually post-operative the patient get benefit. No bleeding anymore, improved the tension inside his buttock decrease. I agree with you, endo has a big role, and you can use whatever you like, coils, any injection, but we've been in a situation we would like to take a fast decision to just try to stop the bleeding, and our current plan to continue with injection sclerotherapy, and even we may need to use any vascular plug or anything like this later on.
You will inject again with ethanol, absolute alcohol for complete closure of this arteriovenous fistula.
You need to
clear
to make as much as you can to make the lesion become more fibrotic, and in the future we can get a chance to excise this unhealthy skin, but after we're making sure there is no more connections.
Okay.
Please, Nasser. To Nasser.
I'm not like Dr. Samah Mustafa. You remember Dr. Samah Mustafa?
As your decision, you decide to for skeletonization of the iliac artery and the ligation of all branches of it. Why didn't you use covered stent in this bloody operation?
Oh yes, very good questions. I'm not keen at all to put any covered stent in a young chap, 35 years, and as you know, the patency rate or the long-term result for any endo is not good. So for a young chap, I don't like to put any covered stent. He's just 35 years old.
Dr. Yasser?
Thanks, Dr. Nasr, for presenting such interesting case. My question is a simple question. How much is the volume of room you can use in such a large case size? And did you prefer using air or oxygen on preparation on your foam?
Maximum, usually I use up to 20 milliliters, but some trial up to 60 milliliter you can use.
Yeah, up to
But
6
for safety,
7, yeah.
yes.
Yes.
You are a strong surgeon, so you can do whatever. But for me, I just
Yeah.
up to 20
Yeah.
in one session.
Yeah. And did you prefer room air or oxygen in preparing foam?
You mean carbon dioxide or oxygen?
You can use oxygen or carbon
Carbon
dioxide.
dioxide may be more safe as regards to the
or,
PE.
or oxygen. You can
Or
use both.
oxygen.
Yeah.
Yes. If you have the availability to use them, maybe much more better. But usually I do it in outpatient clinic with the regular way. Was using
Yeah. Thank you.
just air.
Dr.
But I use clear air.
Thank you.
Okay, Dr. Ashraf. Dr. Ashraf Hidayat.
Dr. Nasr,
Yes.
I congratulate you for trying to solve very serious problems, especially these arteriovenous malformations. In the lower limb sclerotherapy, we usually do distal compression so that no dye will escape or no material will escape to the brain. And sometimes while we are doing the sclerotherapy for the varicose veins, the patient may get eye problem or dizziness. This is a very high fistula, and you
High
inject
flow
20
fistula, yes.
20 milliliters. In lower limbs, we inject maximum 1 milliliter in each side. So you are not afraid of any complications. How can you prevent the escape of the sclerosant material from the high flow fistula or the lesion?
That's why definitely I considered your point. That's why I started by ligation the main feeder, internal iliac and the profunda, just to try to make it a low flow fistula. But you can ask this question for the previous surgeon who did it without any control. He had a brave heart.
Does anyone has an answer for this? A very high lesion, you inject the material, it will escape out of the lesion in seconds. It will go anywhere.
Yeah, sure. Carrying risk, yes.
So,
But our main goal, try to stop the bleeding. So for safety, we just used the skeletonizations. Okay.
Yes, we all know that Dr. Ashraf with high flow fistula needing a big material to close the arterial supply of the fistula more distally, not in the proximal part. So we, in such case, if it is patient come without bleeding, we obliterate the arterial nidus by putting more than one coil in the side these nidus, and this not migrating to any part distal to this area. So in high flow fistula, it is different than the low flow fistula for the management by
Yes,
using
Dr. Shem,
big
and I
material.
just would like to add something. This patient, if you are planning to inject ethanol, he should be under GA and monitoring the pulmonary
Yes.
pressure. So, and inject slowly and see, you want to check the oxygen saturation and et cetera. So,
And if you can using tourniquet during this injection, it is peripheral also.
there is no way to use tourniquet here, is the buttocks.
Yes,
But you can
I-
use external compression, but it
Yes.
doesn't. I think you are if you are planning for ethanol, maybe it's not easy.
now we allowed only one question to every speaker because of the time. Dr. Musad,
Hello?
only one question. Dr. Adel, any question?
Dr. Adil Basha, thank you for tackling this interesting issue. My question is, actually I have a couple of questions. First, we know pulmonary fibrosis is a major complications for bleomycin. How to guard against it? First?
One by one.
Okay.
We have a series of about 70 patients, and the maximum dose is 15 milliliter. The bottle have about 15 gram and dissolved in 15 milliliters. And the maximum dose in this area is 15, but we didn't use this amount. You know the maximum dose over 2 years to avoid pulmonary fibrosis. But astonishingly, we had found that 70% of our patients are satisfied from the first injection. So we don't have this problem. This is one point.
Okay. Secondly, did you try the injection of bleomycin foam or injection interstitial prevascular?
I didn't show the technique. We are using bivalve technique. We are using one scalp, inject contrast material till the contrast material coming from the other side. So we have decided the volume to come to me. We are using only fluid. We didn't use bleomycin as a foam.
Thank you.
Thank you very much.
Thank you.
Dr. Hussam? Dr. Hussam Tawfiq. Is there any question to Dr. Hussam? Yes, clear message. Dr. Yasser?
أيوة.
Dr. Yasser Al-Kiran.
Dr. Yasser, thank you very much for this elegant session. أسأل حضرتك أنا بكلمك أهو ناحيتي. Female patient 60 years suffer from right lower limb edema, moderate edema.
Yes.
هي hypertensive, not diabetic.
Yes.
At night, severe pain.
Yes.
And
itching as well.
how to diagnose أو يعني what is the diagnosis of this
So we have a big issue. We call the old age. We
what
have a big
investigation الأول نعملها لها. نعم.
We have a big issue. We call the old age lymphedema. I must first exclude central cause like cardiac, hepatic, renal, and so on. And usually the cause is dependency. In this age, dependency. If we ask it here, she was always dependent her leg on a chair and so on for a long time. This is the usual cause in such a case.
عملت لها exclusion للهارت failure والهيباتيك causes والrenal causes.
And what about the mobilization? It is mobile or?
ممكن تكون DVT.
It is mobile. It is mobile.
Yes.
Mobile?
أي.
No, not.
لا not bedridden.
Not bedridden or sitting on a chair for a long time.
Mobile and very active.
Album is good as well.
Yes, yes.
No problem, just to
يعني one unilateral edema.
Unilateral.
ممكن تبقى lymphedema ولا حاجة تانية ولا؟
والله could be lymphedema in this age. Why not? Could be lymphedema or recurrent infection, local recurrent infection. After exclusion of a local cause, if unilateral, we must do pelvic CT, pelvic abdominal CT to exclude any pelvic malignancy or masses compression and so on.
Thank you very much, Dr. Yasser. And this is discussion after the session. This is discussion for another case, not for the presentation. We want the discussion for the presentation. Thank you very much. Dr. Wissam Fathi. Dr. Wissam, is there any? Dr. Wissam, thank you for your presentation, but when you inject transvenous especially in the cerebral, intracerebral, you block the arterial feeder by balloon or something like that, or you inject directly, especially the injected material may do infarction or the complication you mentioned in your presentation. How to guard against this?
There are two ways for transvenous embolization. I can do transvenous embolization directly without using balloon occlusion for the feeding artery, but sometimes we can use this balloon just to decrease the flow inside the nidus, to decrease the flow inside the vein, to be able to do embolizing material or to embolize a particle without retrograde flow inside the vein. That's the way.